Alrighty, guys, for this evening's masterclass, we've got Mick Orford of HealthPoint Mingara. So, top-notch physio, our local physio. Tonight is on all things shoulders. So, take it away, Mick.
Thanks, Piers. Hi, guys. Hope you're all staying safe and keeping fit. So shoulders probably, as far as body parts go, probably one of my favorite areas. Both in crossfitting kind of populations and general population, it's probably the second most common thing I see. I'd say, back pain is probably the number one complaint that walks in our door, but not far behind is shoulder pain. It makes sense that shoulders get pretty sore again in general life, and definitely in a crossfitting setting population. So the shoulder, it's the most mobile joint in our body. It does a full 180 degrees movement in our lateral plane, our frontal plane. It can move in again multiple directions, and it normally actually goes through multiple movement planes at once. So, certain joints like the knee, they really act more going in one direction. The shoulder can essentially move in three different planes at once, all in its own little way. And because of that, and probably again because of the mobility of the shoulder, and probably a few particular structural, not anomalies, but just a few particular structural ways in which the shoulder's been designed, or it's evolved over millions and millions of years. It unfortunately is, it's prone to a few more niggles and pains. So I'll go through my general thought process. If someone came in with shoulder pain, to me, normal thing, we sit down, they normally tell me a bit of a story, how long it's been sore for, what may have caused it or not caused it. It's pretty common for shoulders to both have a particular incident. It might be, again, in a crossfitting population, someone's done some snatching or some pull-ups or something overhead, and they kind of associate that with the trigger that caused their pain. But also it can be pretty common too, just to wake up one morning and have shoulder pain. Those particular things can always give me, as a physio, and often it should help the patient figure out maybe some direction of management. So my first tip tonight, with any injury, definitely with shoulder pain though, just always think about how did it come about, and can you put your finger on any particular trigger or movement or activity that you did that might have set it off. That's going to probably save a bit of time for getting to a diagnosis, and also helping, again, formulate a treatment plan.
So just quickly, Mick, to jump in there. So would you say a lot more often than not, it seems to be some sort of inflammation? So a lot of with bursitis, is that what you kind of find more often than not? And it is really aggravated on that eccentric fade from overhead or a front rack position, rather than kind of anything else like a pulling.
Yeah, perfect. No, that's perfect question, Pitt. So yeah, jumping ahead with what's happening in the shoulder. Actually, bursitis itself, it's actually a massively overdiagnosed or overemphasized problem. It can be definitely part of a sore shoulder, but how do I say this in the best way? The most common reason someone has a sore shoulder, when I see them, I reckon, if I'm breaking it up, I'm going to say, let's say I get 100 people with shoulder pain. I'm going to say 5 to 10 of them are going to actually have their neck as the problem, and it's referring pain to their shoulder. So not too many, but it does happen. It's definitely there. And another, probably, 10? I'm going to say 20%, give or take, have, I'm going to call it another structure that is a shoulder issue present, and probably 70% that's left, 70 out of those 100 people, have something to do with their rotator cuff. So the rotator cuff, which is 4 muscles that attach to the point of the shoulder. You've got a big one on the front of your shoulder blade, in between your rib and shoulder blade, and the other 3 kind of live on between the top and the back of your shoulder blade. They all kind of encapsulate the shoulder. They do a lot of different rotation, internal, external rotation, also assist with lifting, and they're always working with any shoulder movement. Even if you squeeze your fist, studies show by squeezing your fist, you actually activate your rotator cuff.
Wow.
Yeah, so it's a super important muscle group for the shoulder, and it's probably the main thing I focus on with most shoulder injuries. And again, I reckon 70%. We call it rotator cuff related pain. Probably 5-10 years ago, it would have been called shoulder impingement. That still gets thrown around a bit. The reason the lingo, the terminology is slowly changing is because impingement probably implies you are compressing and bunching up the tendon and the rotator cuff, and that can be true. I have no doubt. We know that's true, but it's not as common as we used to think. I see a lot of people who get ultrasound for their shoulder, and it's a handy little bit of equipment or a handy type of imaging that can help me guide a diagnosis and treatment. But I'd say on 95% of shoulder imaging, the term bursitis gets diagnosed. And again, sometimes when a bursa is huge, it's massive, I take that into consideration, and it's part of how I treat my patient, and it's part of what we use as valid information. But Pitts, if you or I right now got, this is probably the best way to put it. If every member at CrossFit Plus, CrossFit Human, if we all got both of our shoulders ultrasounded, so we've got 100 and something members, whatever it is, men, women, all different ages, I think the stats would say about 70% of us would all have diagnosable bursitis. So
I believe that.
Yeah, and again, my favorite little comparison for bursitis is it's like, we've all probably got our calluses on our hands from lifting, gripping, some of us from other things, work and whatnot. Bursitis or increased bursal thickening is a natural thing. It's good. It's, if we're consistently compressing that bursa, it's gonna adapt. It has to. Our body adapts in every way to perform at its best. So having a thickened bursa on a scan can get called bursitis. To me, it's not valid. It's not part of a problem. So going back to your question, inflammation can happen. Bursitis can happen. It's not as common as we think. Most of the time, it's the rotator cuff that lives below the bursa. That's the problem. And that can be thickened and irritated, but not inflamed again. We used to use the terminology tendinitis. Itis refers to inflammation. We now use the terminology tendinopathy. So going into what's actually happening at a tissue level rather than inflammation being the main driver. There is a bit of inflammation, but it's actually a small percentage. What our tendons do when they're irritated or damaged or possibly torn, they release what we call a protoglobulin, which is a protein basically that sucks up water. That water content goes into the tendon and we get a thickened, fatter tendon, which actually makes it less tolerant to load, and you can get caught in a bit of a nasty cycle. So inflammation's a factor, not as much as we think. In a really, really bad acute shoulder injury where there's a lot of swelling, bruising, bleeding, inflammation's a big factor. But for most of our members who get a sore shoulder, you're not going to notice any swelling. You're just going to have that lateral shoulder pain, that frontal shoulder pain. And again, bursitis. Inflammation is a factor, but not a huge one. In saying that, anti-inflammatories are very effective to treat a lot of different pain from musculoskeletal medicine. So, just because we don't have a lot of inflammation doesn't mean an anti-inflammatory won't work.
Okay.
I hope that helps.
Sorry. Is there any specific anti-inflammatories you'd recommend? And I know the advice from general doctors and their pharmacists is kind of make sure you take them with food and don't take them ongoing regularly, if that makes sense.
Yeah, definitely, Pitts. Yeah, so I always say this when I'm doing like an interview or something like this, or to any patient. I'm a physio. We're not allowed to prescribe medication, so I always have to, legally say check with a GP or pharmacist. But in saying that, the research and what to do pretty well. So for most aches and pains, a Nurofen or a Voltaren generally is quite adequate. And exactly what you said, general rules of thumbs, the big obvious things I always ask a patient just to make sure they're aware of is, as you said, have them after food or a glass of milk, not on an empty stomach. Again, normally after a couple of weeks, you probably want to back off taking them. Otherwise, there is a high risk of gut issues. And if you're taking blood pressure medication or you've got asthma, they're probably two of the most common things that we check for before prescribing or recommending anti-inflammatories. But often for a lot of these aches and pains in the shoulder, a combo of a Nurofen or Voltaren, not the two together, but one or the other, plus having some Panadol along with that. You can mix those two drugs together. Normally a really relatively safe and low chance of causing any upset guts or anything like that. A really good way just to get on the front foot and settle some pain down. And again, obviously, catch up with someone like me or your doctor or even you, Pitts, getting some advice if it's major. yeah, so a Nurofen or a Voltaren are probably the brands I normally would I wouldn't say recommend, but the ones I'd be taking for myself if I had any niggles.
Okay.
Yes. Yeah, so I guess going back on from what you were asking before, Pitts, with the inflammation, again, it's a factor. It's not a huge one. But more structurally, yeah, where I was going to head with the next part of our talk would be the rotator cuff for, 70% of patients who come and see me is probably the source of their pain. So it's our focus. But I
Yeah.
don't for, unless it's a real true trauma. So unless someone's come up for a snatch or something and they've absolutely like gone backwards under load and their shoulders popped out, so a dislocation. Unless it's something obvious or it's a fracture and they've fallen or they've done something that is not a just generic ache or pain. The key to anyone in that realm is rotator cuff rehab. So if you get just dicky shoulders in general, the research is pretty clear. Don't over focus on scap control. I mean, it's very important. We have a lot of muscles, all our traps, our lats, heaps of muscles that attach to our scaps. And it's important to have good scap control, but it's more likely you'll have poor scap control if you have a weak rotator cuff. So in my head, the rotator cuff is the foundation of the shoulder. So yeah, if I'd have a blanket rule for people to say, how do I prevent shoulder injury? How do I, have a strong shoulder that performs well, not just that feels good, but that actually moves well and works at its best. My number one tip would be just do some rotator cuff, work a few times a week. And that can be, again, Pitts, you could probably name 50 different types of ways to activate, to do some cuff strength. So there's probably, I won't say there probably are a few, I won't say golden ones, but there's a few really simple ones that I give out to most people. But again, jump on the internet, ask Pitts, talk to me if anyone ever wants any particular cuff rehab or prehabilitation. That'd be my number one tip for how to have a healthy shoulder. Look after your.
What if you were to give the guys one rotator cuff sort of rehab you could kind of do quite easily right now?
Yeah,
What
sure.
would it be?
Yeah, so Pitts, my number one, I'll quickly just explain. So, excuse the poor camera angle from me.
You all right?
You're looking at me there. I'm pretty
Yeah.
close. So external rotation is where we rotate away from the body. Internal is where we rotate in. Most pathology or injury with the rotator cuff occurs to our external rotators. So the is that go outwards when we're activating them.
Yep.
When we do an end press movement, we activate our external rotators more. When we do any pull exercise, whether it's vertical or horizontal for both push and pull, for any pull exercise, we activate our internal rotators more, our subscapularis. The reason that is, as we push, naturally our humeral head, our ball and socket will move in a way that we want to activate our posterior cuff to keep it centered, and vice versa when we're pulling. So it's probably why, Pitts, you asked that question before, it's why we see so many more shoulder injuries associated with often a push movement, overhead movement particularly, and definitely a lot of people notice it on the way down. So that eccentric movement, general rule of thumb, an eccentric contraction requires more energy. It's more taxing on our musculoskeletal system. So, you're doing a push movement in an eccentric fashion, that's probably the most load you're going to put on your external rotators. So that's why when you ask what's the best one exercise, I'd always say some variation of external rotation. So general rule of thumb, I'd say my favorite thing I give anyone with pain or even as a pre-exercise, pre-workout thing would be just do some isometric stuff. So that might be as simple as walking up to a pole, the pole's on the outside of my hand, and just trying to push the pole away. Again, doing that static isometric contraction, doing 3 or 4 15 to 30 second holds on the side is perfect. Or even, hold a skipping rope, hold a band and try and pull it apart, again, in an isometric fashion. I reckon that's bang for your buck. And if you get dicky shoulders, if you did that every day, a few times a day, just a few 30-second holds a few times a day, I'd say you've got more than a 50% chance that'll fix your shoulder pain without doing it.
Yeah, right. That's very interesting. Good to know. Good to kind of.
Yeah, bang for buck and simple.
Yeah.
You drive in the car, there's a lot of times I have patients where they go, we all struggle to do homework, but
Yeah.
right shoulder pain and you're driving in your car, push into the door. Again, it's probably one of those exercises that I really say there's no excuse not to do it. It's so easy to do.
Yeah. Yeah. Cool.
Yeah, my golden exercise, probably the most simple one you can give to.
Awesome and easy to actually do. It's just simple and easy, and there's no reason not to do it, right?
Yeah, exactly right. Especially, obviously for performance and definitely for probably pain particularly. Yeah, it's so easy and it probably works better than pain management, to be honest. The reason is it's just as effective as taking painkillers, doing that too.
Unreal.
And so, yeah, it's crazy. Yeah, I'll keep going for a bit, so I can talk about this all day. I don't know what we're up to for time-wise, but as I said, rotator cuff, number one, foundational thing to look after for a shoulder. Look after that. Very unlikely it's going to go that wrong with you unless it's a traumatic event. You drop a weight in an awkward way. Unfortunately, that can lead to pain. But most of these shoulder injuries are from repetitive use. We're doing a lot of overhead. You might do a big session of push press or something, or some jerking, and have that foundation of a strong cuff, and 100%, I'm confident that there's a much less chance that you'll wake up the next day and go, I need to go see physio, or I need to have a few days off the gym. Other things apart from the rotator cuff that come in IC would be probably AC joint issues. They're not that common in CrossFit populations unless you're doing huge overload kind of sessions of shoulder press, or maybe a lot of dip work as well. It can happen. More likely to occur from more trauma. So, more footy player in the weekend to get tackled or fall and land on their shoulder. But it can happen. In our older members who are probably in their 50s plus, it can be a valid reason. You can get a bit of arthritis in that AC joint. So that's the acromioclavicular joint. It's the joint where your shoulder blade and your clavicle, your collarbone, attach to each other. Again, not that likely, but it's out there. There's a few taping strategies if people are getting issues there that I'd always be happy to show them. So, if you've been told or you think you've got an AC joint issue, always feel free to get in contact. I can kind of send you a little link to a taping strategy that might help. The other one would just be the mobile shoulder. So there's probably a few of our members, shoulder dislocation pretty common. Dislocation is essentially where our ball falls out of our socket or it's forced out. Some people in our population, they just fall out. Some people are hypermobile and they unfortunately just have laxity and they almost, they don't fall out, but they, with much pressure. But most people are from trauma. So again, probably from a younger time, maybe at CrossFit, they've unfortunately gone back. It's pretty uncommon, but it happens. Again, the same rule applies if you have an unstable shoulder joint, a dislocated or sublux joint. Rotator cuff is key in saying that you do want to have some really good, strong global muscle activation too. So you need to make sure pecs, lats, traps, all the big global muscles are working in the right way. So we're not kind of pulling in one direction too much, depending on what way it's popped out. They'd be the kind of big other issues I see. And the last one, would be bicep pain. So long-headed biceps. Our biceps got two muscle bellies. One attaches kind of in our chest, essentially, and the other one comes up through our little bicipital groove, deep into our shoulder socket. The long-headed biceps, it's a really long, skinny tendon. It's probably it'd be inches and it's really prone to irritation too. So if you're getting frontal or anterior shoulder pain, my big things that often I find with gym populations, including CrossFit, that rev them up would be dipping or, bench press or chest press or even push-ups where you're going past horizontal. So number one tip, if you get really frontal shoulder pain, modify bench, push-ups and dips. The main modification is don't let your elbow pass the flank. So,
okay. So, we'll just froze it for a sec, buddy.
All right.
Yeah, so, there we go. Start it. Yep.
Yeah, cool. So if you're getting long-headed bicep pain, try not to go into shoulder extension under load. So that would be particularly your horizontal pushes, including chest press, push-ups, and dipping. Particularly dipping is probably one of the worst ones for the long-headed bicep. So Yeah, that's the other main thing I see besides rotator cuff issues would be long-headed bicep in a CrossFit population. So Bert, you had a question, I believe.
Yeah. Let's just finish with that question. Another question had come through.
Perfect.
Hang on, it's just.
Yeah.
Hang on, let's go again. The internet just went glitchy. Silly whiffy.
Yeah, so Burge's question was around just shoulder prehab, including just simple, easy home exercises. As I said, quickly, just isometric rotation. Again, holding a towel, pushing against something static or whatnot, just holding and doing an isometric contraction would be the easiest number one thing. Otherwise, my other favorite one would be, at night, if you're watching a bit of telly, get on your side. Get on your side, so be on sideline and watching television and just doing some nice, slow external rotation. Doesn't have to be heavy, and particularly focus on that eccentric phase. So that's the lowering down phase. They'd be the main two, Burge. Otherwise, again, more advanced stuff. Just everything we do at CrossFit, we're still working we're working the rotator cuff. It's almost doing a well-rounded, well-programmed plus CrossFit program it's prehab in itself. So, just trying to keep balanced, I guess some old principles that still hold true, not doing too much pull, trying to, roughly keep it even. There's a common saying you should be doing more push. There's no evidence to say that's true, but I'd still probably agree with it from what I see. I'd say, you want to be doing probably a little bit more pull than push, only because, again, when we do push exercises, we're overloading and using those external rotators, which often get flogged a bit. So, again, I won't say do more pull than push. Just keep it balanced and listen to your body. So, and just keep an eye on your training. Obviously, most programs won't do one or the other too much. If we're doing some push press is our focus for that cycle or whatever, I'm sure there'll be a lot of accessories in there for pulling to balance that out. So hopefully that's simple. So again, just external rotation all day, every day.
Well, that's pretty good. Like, there's so much knowledge in there and a lot to take away. I've took a lot away from that for expanding my knowledge, but it would have got a bit sciencey for people. But the biggest thing that I've seen when you went back to just kind of standard stuff for people to absorb was just how simple a couple of corrective movements and stuff you can do in your day-to-day life. And like with that last thing you were saying there, rotation, just had a dumbbell, especially in this time, we've seen so many people just using odd objects around the house. You just need a light load for that. Grab a 500 gram bag of flour or anything, like a nice brick. There's so many things. You've obviously got something that's like kind of a kilo in weight, not even, and just get it moving. I guess worst case scenario, as long as if they don't have any load, at least I guess something's better than nothing, so to speak, and just moving to that range of motion with no load, no external load.
Yeah, definitely. And even without equipment, again, find an immovable object, go to your wall, go to a door frame, go to your bed, whatever. If you want to up some load tolerance, we need to load, obviously. Push as hard as you can against those objects. They're not gonna move, and you're gonna generate the equivalent of lifting something that's actually quite heavy. So exactly. You don't need equipment. If you've got it, perfect, make use of it. But you don't need equipment to do a good little cuff program, without a doubt.
Awesome. All right, no worries, Mick. Thank you so much for giving us your time tonight. As I said, so much knowledge in there. We know you can find Mick over at HealthPoint Mingara, just a tummy there, right near Mingara Recreational Club. Jump on too if you want to contact him direct. Jump on, find his details on the website, which run me through the handle for the website.
Perfect. And Pitts, when you post this up, guys, if you watch through and anything doesn't make sense, again, if I got a bit heavy with a bit of jargon, I do apologize. But any questions, just tag me, just ask the question, and I'll jump back on and I'll write back to you on our Facebook group page.
Awesome. Thanks, mate. Really appreciate it.
You guys, stay safe, and I'll see everyone soon.
Thank you.